everybody, welcome to the New Zealand Shoulder Elbow Therapist Conference here in Arrowtown. I'm Margie Old and everybody's going to introduce themselves and then enjoy our podcast.
Hi, I'm Pradnya. I'm a physiotherapist from Auckland.
Hi, I'm Lisa Hanson. I'm a physio and hand therapist from the Waikato, and I'm the matriarch. I'm the oldest.
Hi, Angela Cadogan, specialist physiotherapist from Christchurch.
Hi, I'm Sarah Betteridge, physiotherapy specialist in shoulders in Christchurch.
Hi, I'm Paul Timothy. I'm a physiotherapist in Christchurch.
And I'm Jane Dickerson. I'm a physiotherapist in Dunedin.
So welcome to our chats. I hope you enjoy the podcast.
Welcome, Dr Jacqui Clark, to our Fireside chat here in Arrowtown in New Zealand. So Jacqui is a New Zealand-based physiotherapy specialist with a subspecialty in pain, but I know from teaching with Jacqui and spending some time with her, she does also have a background in kinetic control, motor control, and does also have an interest in the shoulder as well. So thanks for taking the time to join us, Jacqui, and
you're welcome.
Get on to some questions for you.
Yeah, thanks for having me. This should be quite exciting. So we've only got half an hour, haven't we? You'll have to stop me if I get too excited and talk too long.
Yeah, go Lisa. Come on up. Hi, Jacqui. Lisa Hanson from Hamilton, Waikato.
Hello, nice to see you.
I've got a big question for you. What are your top tips for us on how you subjectively and objectively label your patient's pain as either neuroplastic, nociceptive, or nociplastic?
Yes, okay. So you mean nociceptive, neuropathic, and nociplastic, all the ends. Well, if I may just share a few little slides. Can you see the screen from where you are? Okay. Ange does have a few of these slides, but I could send you a copy if you'd like some later on. I thought I might just show you some slides because I'm quite a visual person, so it would help to go through it visually. So when you have a patient, a shoulder patient or a musculoskeletal pain patient who has complex pain and doesn't seem to be responding to the normal input that you're giving them, then the next job is to really establish which pain types we're dealing with, which is what I think you're asking. So the goal is to work out whether we have predominantly nociceptive, which is your classic inflammatory musculoskeletal injury style of pain, or whether you've got nerve damage, or whether it's become nociplastic, which means there are neuroplastic changes within the brain that are now generating their own symptoms, which gets a bit more complicated. So what I'll do, Lisa, just to answer that question, is to go through how I would assess for each pain type. So we'll start with, I've gone the wrong way, sorry. I've got this new laptop and it's doing the mouse back to front to what I'm used to. Forgive me. Oh, gosh. That's all part of subjective, which I'm not going to talk about in detail. But what I'm saying is that you often do have a mixture, which is where I think the questioning is going to lead today, is how do you determine which is the predominant pain mechanism and making treatment priorities according to pain mechanism. So if we start with the neuropathic pain, there are guidelines that are published, the FINERUP 2016 guidelines, which go through this clinical algorithm. So they've got pain, obviously, but if it's neuropathic, then there is damage to actual neural tissue. So usually it's been crushed or stretched or compressed, and it's no longer conducting normally. Neurogenic is where there might just be some fluid buildup around the nerve root, which is just creating some irritation on the nerve root. But neuropathic is actual nerve damage. And sciatica is an obvious example where you've got a disc pressing on a nerve, or a cervical disc pressing on an arm nerve, of course, brachial plexus. So the way to tell that is that it's neuroanatomically plausible, as in it's dermatomally distributed. So if you've got pain down a particular strip of the arm into a particular side of the hand, then you're looking at a particular nerve that supplies that's likely to have been damaged. So if it's anatomically plausible, meaning it's dermatomal, then it is possibly neuropathic. And then you do the sensory signs. And again, you'd expect numbness, tingling, or hyperalgesia in particular dermatomes. So then if that's the case, then it's probably neuropathic. and of course there'd be an injury related to it. So it's got to have some mechanism that's likely to have damaged the nerve as well, like a dislocation, a shoulder dislocation, upsetting the brachial plexus on its way past. But to confirm that, then you'd either need an MRI scan to confirm, say, a disc bulge against the nerve, or nerve conduction studies, nerve conduction studies are limited to conduction, of the nerve, obviously. So it's to do with the sensory and motor conductivity of the nerve. When you talk to Michelle Capiters, who's one of our physio researchers in Australia, who you may have heard of, who does a lot of work with neurogenic pain and neuropathic, he thinks that this is a little bit restrictive in our definitions, because you can have a couple of dermatomes and therefore it may look more widespread. But on the whole, this is a reliable way to tell whether or not you're dealing with neuropathic pain. And then if you want a quick screening, I would use the Lance Neuropathic Pain Score. Are you familiar with that, or shall I show you that as well? Okay, so it's a quick screening. I've got it up ready for you. It's a quick screening score here. It asks questions like, in the area where you have pain, do you also have pins and needles, tingling or prickling? And it would be a score of 5 if it's a yes. Color changes, which could overlap with CRIPS, but don't forget CRIPS, especially cold CRIPS, can come after neuropathic injury. And does your pain make the skin feel abnormally sensitive to touch, usually in that dermatome? So and you can get them to just lightly touch the skin in the area. Do they get electric shocks, random electric shocks, or jumping or bursting sort of sensations? And then you get them to do 2 little rub the skin, press the skin. Does it feel unusual, like pins and needles, tingling or burning? Or does it feel numb in that dermatome? Now, the reason I keep saying dermatomal is because obviously the nerve will supply that particular dermatome, and that's how you tell the difference between neuropathic pain with evidence of nerve damage to confirm it, and non-dermatomal numbness, which is another thing I'll talk to you about later on, which is more associated with nociplastic pain. That's the way the brain is not reading information accurately from the limb, and it's lost its acuity, so it's numbish. So the Lance pain score is, I've got a copy. I can send it to you, Angela, if you'd like, and then you've got copies if you haven't already got one in your clinic. Really quick, easy screening for neuropathic pain. So that's how you would check for neuropathic. Going back to the slides. And the one that I think you're probably more interested in checking for is nociplastic. So with nociplastic pain, it used to be called just central sensitization. So most people knew something about central sensitization in that they know that's the chronic type of pain. But actually, central sensitization is where the soft tissue area of injury becomes really, really sensitive straight after an injury. So it becomes sensitized through peripheral inflammatory mediators and central mechanisms to protect it, so that people will look after it and it'll heal. So in the first week or so, you expect some normal peripheral and central sensitization. So what the researchers were saying was there's not enough distinction between, acute central sensitization and now chronic central sensitization if that maladaptive response continues, or that adaptive response for protection continues maladaptively at 3 months and onwards. So they got their heads together with the International Association for the Study of Pain, IASP, and redefined it, the chronic version of central sensitization, and called it nociplastic pain, which was only published a few years ago now. So the clinical algorithm for that is that pain needs to have been present for more than 3 months. So if it's new and less than 3 months old, it's not nociplastic yet. There may be some alterations happening neuroplastically to create nociplastic pain, but it's not, strictly speaking, called that until it's past the 12-week mark. And you'll find that that sort of pain is more diffuse, so it's not dermatomal. It tends to move around as well. Sometimes it can swap sides and mirror, and it'll not have your normal aggravating and easing factors that you get with nociceptive pain. Because with nociceptive pain, if you've got some irritation in the subacromial space, for example, and they're always going to catch in that abduction position or medial rotation flexion position, it's reliable. It always catches then, and then when you're out of that nipping position, it doesn't catch, so it's not painful. That's your regular, clear aggravating easing factors, which is what we would always like to see. But by the time it's been around long enough, it's not that predictable. It tends to get worse on rainy days, or it gets worse when they've had a fight at home, or they get worse when they've got other stressors in their lives. And that sort of unpredictability of it tends to point to nociplastic pain in that it's regional rather than specific, and it's unpredictable. So regional, not discrete pain, as in it's not specific to the anterior shoulder, for example, points towards nociplastic. You rule out a predominant nociceptive pain mechanism. So if it's entirely responsible and nociceptive, it's not nociplastic. If it's entirely neuropathic, then it's not primarily nociplastic, but often these do coexist, as you know. And so if you've ruled out predominant nociceptive and neuropathic pain mechanisms, then you explore the other factors in the subjective questioning, including the multisensory sensitivity, so light and sound sensitivity, fatigue, sleep disturbance, waking up unrefreshed in the morning, brain fog. Mind you, most of that applies to some of us, doesn't it, with menopause? I mean, you do have to talk about, other things like hormonal factors, but a lot of these do overlap with other conditions, like a chronic fatigue syndrome is a very nociplastic pain generated related syndrome, fibromyalgia, and they come with brain fog and those things that happen with fatigue and other comorbidities that go alongside nociplastic pain. Because the changes that are happening in the central nervous system, the neural components and the hormonal components and the endocrine components are all interrelating with each other. And so again, the aggravating and easing factors can be as unpredictable as hormone balance and hormone sequences in females as well. So you've got all these other factors that make it a very unpredictable type of pain for people to be managing. So then you do your evoked pain hypersensitivity testing. So you've done your questioning, your subjective, and you do your objective testing, and you find that they have allodynia, hyperalgesia, which is all hypersensitivity. So Lisa, you probably will have noticed in some of the reports I talk about allodynia and hyperalgesia. So usually what that means is I've gone through testing cotton wool. Is that hypersensitive or is it numb? Compared with the healthy side, and particularly is it painful? Some people go, "Oh, I don't like that," and it gives them an autonomic response, and they go all flushed and they feel yuck just with cotton wool, and you're thinking, "What's going on?" Well, of course, you know what's going on. It's an autonomic response to a very unpleasant sensation, which is to us just cotton wool, but that's allodynia. It's called allodynia. And hyperalgesia is something that's normally uncomfortable, like poking with a sharp, pinprick hyperalgesia. I use either the end of this 2-point discrimination tool here or a paper clip unfolded, which I had a moment ago. It's slid under something. Just unfold a paper clip and do the same thing. And so you might be doing it around the shoulder if that's where they've got their widespread pain, or forearm if they're getting sort of Cripsy type looking symptoms. So those are the evoked pain hypersensitivity phenomena in this algorithm. And so if you've got those, then you're looking at possible nociplastic pain. If they also have those comorbidities, then they have nociplastic pain. And at the bottom here, I said that nociplastic pain can be either or both central or peripheral sensitization. So if you've got someone with an inflammatory disease like rheumatoid, say, or an active arthritis, then there can be some peripheral sensitization driving some of the pain, which is actually nociceptive, of course, but driving the nociplastic component through the central sensitization process. So central is the brain and spinal cord, and sensitization is where it amplifies all the sensations. So they might have a bit of impingement pathology, or they might have a bit of a roughed up labrum in the shoulder. But normally a person might feel like that's uncomfortable, but they can tolerate it. Whereas someone with central sensitization, because of anxiety and poor sleep and all the other factors that drive that central sensitization, they really feel it because it's amplified. So I never say to a patient, well, you haven't got, there's nothing wrong with it, it's just central sensitization, because often there's both. So I'll explain to them, well, yes, there's a bit of pinching going on. We need to get that scapula to stop dropping the roof of the scapula onto the tendon, for example, depending on what we're talking about, so that it doesn't give it the nipping pain, which then is amplified through your brain and spinal cord. Because it's that amplification of it that makes it so unbearable and makes it spread, and it becomes so much more disabling when it's amplified. And it's amplified through the threat evaluation of it too, because often these people have had past traumas, and they're often very threat aware, and their brain is evaluating for threat all the time. And so when they feel a pain and they think that's really quite dangerous because it's going to cause more harm, the brain amplifies the pain to warn the person of it. So that's the sort of one of the mechanisms behind this amplification process, is this heightened threat alarm in the brain and spinal cord. So that's how I would recognize nociplastic pain using this algorithm. So are there any questions so far on that part?
Not from me.
That's
That's
great.
great.
Thanks.
All good? Keep going?
Yep.
Yeah.
Okay, interrupt any time if you want
I've
to
just got
ask.
one question. With the past experience you were saying of trauma,
Yes,
can you elaborate a little bit more?
yes, absolutely. How long have you got?
Yeah, you've got 13 minutes, Jackie.
Yeah, don't get too held up on that then, sorry.
Okay, no, so I can't actually see who's talking, but hello, whoever you are. What happens in trauma is that the brain becomes wired to realize that the world isn't very safe. And so the brain becomes more heightened in its need to protect the person, obviously, because our brain is designed to protect us. So when it's experienced trauma, it becomes a lot more threat aware, and so is much more hypervigilant for threat. So light and sound becomes a lot more sensitive because it's got to let more information in to continuously screen for potential threat. And light touch becomes a lot more sensitive. So even clothing can get really irritating. And that's because the brain's heightens its senses in order to detect threat as soon as it possibly can. So past trauma wires that threat evaluation system to be much more easily triggered and sensitized. So the senses become a lot more sensitive because of that.
And Jackie, can that past trauma, are you talking about a physical trauma?
Yeah.
Can it be mental trauma?
I would say, good question. Yeah. So a trauma is defined as anything that was out of the person's control. So it felt really out of control, and it set off a big physiological hyperarousal response. So that can be a huge emotional trauma, like a big shock or something that's happened, like a sudden loss of a husband or wife or something like that, or parent. Or, of course, it can also be a very sudden a motor vehicle accident, so a physical trauma, as well as the shock of that happening. So shock is involved, and feeling out of control is involved in trauma. So it can be emotional or physical, and it can happen from childhood or in adulthood. So childhood trauma is said to be somewhat worse because the young brain then becomes wired much younger for threat. And so these young people have a lot more trait anxiety, so they're much higher in trait anxiety. And trait anxiety is a stable trait through life that means that person tends to respond to perceived threats with a much higher fight-flight response in the body. And fight-flight is that physiological hyperarousal, which is central sensitization, effectively. Everything becomes really, really sensitive. So if you have a tendency for that, and then you injure your shoulder, the threat of losing your job, the threat of being re-injured if you do something you shouldn't do physically, is much more heightened in that person because they're more wired to evaluate for threat. So one of the things I do in my assessments is I evaluate for their coping style based on trait anxiety and defensiveness as it happens, and you combine them to make a coping style, which is already well validated in the research. And if they are a defensive, what they call defensive high anxious, those people tend to be constantly checking and hypervigilant to check that they're safe, and they'll evaluate sensations and evaluate potential situations for threat. So their whole fight-flight system is on the go and they're highly sensitized. So then the brain is predicting, well, if I do that, that's going to be sore. So lo and behold, they do something, and that evening they're really, really sore, and they don't really know what it was because they flared up later on. That's another little telltale, by the way, of nociplastic pain. Nociceptive is very reliable. Pinch, ouch, don't pinch, no ouch. You know, I'm simplifying it, of course, but there's a much more mechanical presentation with nociceptive pain, and it's there and then. You irritate that tissue, you feel it now. You don't irritate it, you stop feeling that pain now. Whereas with nociplastic, they do their task, and then later that day or night, it all flares up, and it'll be flared for 2 or 3 days. So that's the neurophysiological fight-flight system and threat alarm system heightening the neuroimmune sensitivity. Because central sensitization is a bit like having a virus. You know, at this time of year, we've all got flu viruses going around, or you get a nasty virus and you ache and you're stiff and sore for a couple of days. That's central sensitization because the neuroimmune system has raised its inflammatory level in the CNS to fight the threat. And so that's the same feeling of that whole sensitivity and sore and achiness as someone who gets a flare up in terms of that neuroimmune system gets heightened to fight the threat. But the threat wasn't a virus, the threat was a perceived threat. It still does the same response though. I think I might have answered that question for too long. Did that answer the question?
Wonderful.
That's phenomenal.
I think just to close it then, Jackie, do you have anything that you think is really important for clinicians to know? Like if you could tell clinicians one thing about the type of work that you do, or what you would like clinicians to take away from listening to this, what do you think is most important for them?
I think that if the person has sensory alterations, as in they're either heightened to senses or they've lost large areas of sensory input, which currently would be measured as not classifiable pain. If we go back to that algorithm, at the moment, the IASP says that if you've got no hypersensitivity, but you've got everything else, it's not classifiable. So one big thing that I'm pushing worldwide now is that the nociplastic pain can also include big patches of numbness. And so what I would say is if you find somebody has anxiety, stress, poor sleep, and brain fog and the other factors that go with it, look at their bigger picture. And if they're hypersensitive, with or without big patches of numbness, they need to have their senses retrained, their sensory accuracy retrained, so that they can feel safe in their body again. Because someone that you've got with shoulder pain and you're trying to get their scapula, beautiful upward rotation, and you're trying to get the cuff recruiting, they're not going to do that if they're frightened and it's threatening and it's all too sore and they don't understand why, and it could be damaging what you're doing and they keep flaring. So if it's nociplastic pain, safety, 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 explain this to them, explain that the brain is ready to fight threat and it thinks that even touching it's going to damage it. bring down that threat evaluation first,
Mm.
then restore some sensory feel back into it, some normal sensory acuity using 2-point discrimination or texture discrimination, discriminating between rough versus soft, spiky versus smooth, and get them to really feel the area again, get them to feel the scapula. So go for feel first, because sensory drives motor. And once you've got your sensory back, you get your motor back. And
Yeah.
it feels safe. If you can't feel it, it's not safe
Yeah,
to
okay.
them. So they flare up, they blame you, they go to someone else.
You
So if I had to
we
just,
actually had loads of questions, and maybe we should reschedule another
Yeah.
post Fireside chat where we could actually ask you some more questions. So
yeah,
would that be okay that we could do a part 2 of Jacqui Clark that's not so
why not? Why
not
not?
so condensed? So
You did ask for a few papers. I mean, look, I'm looking into ADHD at the moment because ADHD they don't process normally. Huge number of people with chronic pain have ADHD, and
yeah.
also been working with the Howard Schubner group on how to reprocess that pain and that threat evaluation.
Okay, well let's schedule. We'll be in touch with another time. That would be wonderful.
Enjoy the rest of your evening.
Okay, thank you.
Bye.
Yeah. Thanks for joining us. Cheers.
Cheers.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media. Don't forget you can follow me on my social media for some more up-to-date content. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.